Let me get myself off of mute. All right, everyone. Good morning. My name is Nervese Flint. I am the policy director here at Black Women for Wellness. I say here, I'm at home, but here in Los Angeles. And I wanted to welcome everyone to this very special Roe v. Wade event where we are talking about Roe and Black women. So I am, we have a all-star exciting group of folks who are going to talk to us today about realizing the promise of Roe in Black women and reproductive choice, but also reproductive justice, right? Because Black Women for Wellness is a reproductive justice organization. So, with all that, because we have such a fabulous panel that I will get up to and I will introduce everyone. I just want to go over some of the house rules. I say house rules, but just how do we use Zoom? The first piece, if you want to ask any questions, you can use the Q&A. Please use the Q&A for it's able for us to track the questions and be able to answer either in real time or type them. And if we don't get to all your questions, we will be able to follow up later. We use the chat for the amens, the sprinkling fingers or sparkly fingers and all those pieces, our technical difficulties. So questions in the Q&A, in the chat, we're going to use the that's the amens corner. All right, and so now what we have the official how do we use Zoom together. I am going to introduce our first panelist, and this is because this is going to be our hot topic moment, because usually when we do hot topics, it's a community conversation, but because this is a special event, we have somebody leading the hot topics. And so I'm going to pull up her bio real quick because I'm bad at memorizing a lot of these things, but there you go. So it is Tanisha White. So Tanisha's first love is community, and she has used her skill set to both cultivate safe and safer spaces for and amplifying the voices of queer BIPOC folks. And for folks who don't know what BIPOC means, is Black, Indigenous, people of color, particularly particularly within a reproductive justice and anti-violence framework. She has years-long experience with reproductive rights, focusing organizations including NARAL Pro-Choice Virginia, Progress Virginia, and Newly Planned C. Her work has focused on organizing policy and communications, in addition to volunteer relationships with the National Network of Abortion Funds and the Richmond Reproductive Freedom Project. In her city, Tanisha co-organizes a period poverty campaign she co-founded entitled Campaign for Comfort, RVA, which couples digital awareness with an ongoing menstrual project dive. In addition to these organizing efforts, Tanisha's writing career focuses on marginalized voices, sex positivity, and wellness. And so super excited to have Tanisha to come break open our hot topics with Plan C. So I will turn it over to you, Tanisha.
Hey y'all. Definitely happy to be here. Can you hear me okay?
Yes.
Okay, great. Um, Thank you for reading my entire long bio. Didn't realize you were gonna do that, but that's okay. Um, and definitely always happy to be here with BWW. I am currently based in Virginia, so it's always nice to talk with folks on the other side of the U.S. and see what everybody's up to. But yeah, I wanted to give you all a quick update with what's going on with Plan C. For those of you that don't know, Plan C's primary mission is to communicate and spread the word about abortion pill access, and to share resources with folks who are seeking abortions, folks who want to aid people in accessing abortions. So, with the new Supreme Court ruling, there's been a lot of fear and people being worried about what does that mean for folks, what comes next, and there was definitely a lot of scurrying around on the Plan C side, trying to determine exactly what it meant. Um, And really, the federal restriction came down to the dispensing of mifepristone, which is one of the two medications needed in a medication abortion. So mifepristone is the first one that you take, and then a day or two later, you take the other two misoprostol pills. So mifepristone is the one that's been being regulated. So there have been headlines in the media, saying things like justices say that women have to obtain the abortion pills in person, but in reality, the restriction isn't that definitive, and it's really about the dispensing. So a lot of these headlines have oversimplified and really misinterpreted the restrictions, and the judges haven't ruled whether or not they can be mailed. So in reality, folks are still able to access their abortion pills. And the biggest change is that there's been, due to COVID, there were some loosened restrictions around access. So really, what this means is that we're just in the same position that we were prior to COVID. So folks have to, do their due diligence and reach out to the available legal resources like if, when, how, and things like that, to figure out what it really means for their area. But I think the important thing is stressing that people still have access to the care that they need. Um, and people have been asking, what they can do on their end. And I think one of the most important things is spreading the word, talking to folks in your circles, and also, being scrutinous when we see news headlines talking about, limited access and what those things mean. And of course, on the Plan C website, there is a guide, and you can go to the guide and look to see what your specific regulations are in your area, as well as different ways to access. And there's still lots of options, whether you want to do self managed or if you're looking for telemedicine. There are a lot of options in California and in other states as well. So that is pretty much where we are now, continuing to try to push the message out about the access to abortion pills, and mitigating some of the confusion that's been happening around the recent court ruling, but also supporting our partners who are aiming to hold new administration accountable, for making things even more accessible.
Thank you. That was really informative. And I know for me, January 20th, I didn't realize how much of a weight was taken off of my life. And as we think about abortion access and Plan C and what that means, and what I'm really excited about is to have a conversation um, about abortion access as we move into the Biden campaign, because even though there was a lot of good things that are about to oh, uh-oh, I think my internet popped off. Sorry, y'all. So my apologies. Does everybody can hear me? Yes. Okay. Never had that happen before, but um, oh, the days of Zoom. But I was just saying how excited I am to get into the conversation, because abortion access is one of those issues that we know is still going to be a problem still in the Biden campaign. And having conversations about Plan C is actually still really, really relevant, even though we have a different president. And so, with that being said, I want to jump straight in, but I want to give a proper introduction to what we're talking about here. The outgoing administration judicial appointments have tipped the balance of the Supreme Court and federal court in the direction of abortion rights restrictions. What does this mean for Roe? Our esteemed panel will guide our discussion on the status of Roe. We will explore the ways that access to abortion care have been strategically denied and the resulting impact on Black women's rights to exercise full body autonomy. We will also discuss our demand demands and the Black reproductive justice agenda to maintain, improve, and ensure access to the vital component of reproductive health care. So with that, our first person who I am very happy to introduce, and person I also call friend, but I'm also about to murder her last name, Fabiola Carrion. Fabiola, okay, I got it. Okay, cool, because I was just like, dang, for years I know you, I can't mess up your last name. So Fabiola is a senior attorney at the National Health Law Program, an organization dedicated to protecting and promoting the health rights of low income individuals, excuse me. Based in Los Angeles, Fabiola works to expand access to reproductive healthcare services and public and private health insurance programs across the country. Before joining InHelp, Fabiola was an advocacy program officer at Planned Parenthood Global, where she designed, developed, and oversaw projects on sexual and reproductive rights in Latin America. She also served as the director of government relations at Planned Parenthood of New York City and as a policy advisor for a network of progressive state legislators and state-based advocates from across the United States. Fabiola began her legal career as a law clerk for Judge Joseph Maltese in New York Supreme Court and worked for various national and international human rights organizations before and during law school. Fabiola is the person who I always go to if I have questions about what's going on with abortion access, and always comes with all the answers. And so we are super excited. And I am personally humbled and honored to pass the mic to Fabiola to tell us like what's going on.
Thank you, Norbese, and thank you, everyone. My name is Fabiola Carrion. I'm an attorney at the National Health Law Program. I also come to you as an Indigenous and Black Peruvian, an immigrant, and the daughter of a factory worker and a public school teacher. I am beyond honored and frankly starstruck by the panel that's here, by Norbese, and everyone who's part of this conversation. I'm here to speak about abortion rights and limitations, what is at threat, and what we can do. Let me start by acknowledging the contributions of Black women who created and have maintained the reproductive justice framework and movement. While I work for a healthcare advocacy organization, I will attempt to include a reproductive justice analysis in my advocacy. I hope to honor your work and trajectory. The National Health Law Program, like Norbese said, defends and protects the healthcare rights of low-income individuals and underserved communities. We opened our first office here in Los Angeles, actually as part of the UCLA School of Law. And we have two other offices in Carrboro, North Carolina, and in Washington, D.C. We work on issues related to children's rights, people with disabilities, and older adults, especially as they pertain to healthcare coverage, Medicaid, and the Affordable Care Act. We also proudly and unapologetically work on abortion because abortion is healthcare. In fact, abortion is a common health intervention. An estimated 1 in 5 women will have an abortion by the age of 30, and 1 in 4 will have an abortion by the age of 45. 28% of abortion patients are Black, 25% are Latinx, 6% are Asian or Pacific Islander, and 3% identify as other. This means that 60% of the abortion population is comprised by women of color. On this day, in 1973, the Supreme Court held that there was a constitutional right to abortion in Roe v. Wade. However, this right is not accessible to many, particularly Black women. Almost 60% of women of reproductive age live in hostile states to abortion rights, according to the Guttmacher Institute. Since 2011, More than 450 laws have restricted access to abortion care in states across the country. In just one state, the state of Louisiana, with a predominantly Black population, has 89 restrictions that impede access to abortion care. I will name just a few. Gestational age bans, bans at the 6, 18, and 20 weeks of pregnancy have been enacted across in various states. Mandatory ultrasounds, forcing abortion patients to look at the ultrasounds before getting their abortions. Mandatory counseling with inaccurate information, forcing providers to tell patients that abortion causes breast cancer, which is absolutely false. Bans on abortion, allegedly based on race, sex, and disability. Waiting periods ranging between 24 to 72 hours. What does that mean? It means that once a person has decided to get an abortion, finally gets an appointment with an abortion provider, gets the counseling in order to get the abortion, then that person has to wait 3 days between that first counseling session and their abortion procedure. Method bans, bans on the telehealth delivery of abortion have been enacted in 17 states. Bans on dilation and evacuation, one of the most common methods of abortions at the second trimester. Prohibition on insurance coverage of abortion in public, marketplace, and private plans. And I'll speak about the Hyde Amendment shortly. Mandatory parental consent laws. Targeted regulations against abortion providers with onerous and necessary requirements for abortion providers that neither help them nor the patients that they serve. Trigger laws, making abortion illegal if Roe v. Wade is overturned. Those are just a few of the restrictions on abortion access that have been enacted in this country. And the COVID pandemic did not stop anti-abortion politicians. Last June, Tennessee legislators approved a bill that bans abortion once cardiac activity is detected at around 6 weeks and punishes doctors who perform abortions for up to 15 years in prison. A week later, Mississippi passed a recent ban that imposes criminal penalties on doctors who violate this law, which requires providers to interrogate their patients about the reasons for seeking medical care. In the midst of the public health emergency in 2020, governors in 11 states, principally in the South, used the pandemic as an excuse to restrict abortion care by classifying it as non-essential. And today, on the anniversary of Roe v. Wade, on January 22nd, 2021, legislators in Kansas, Maine, Ohio, Kentucky, Iowa, Arkansas, and Mississippi have already introduced bills ranging from banning abortion altogether to prohibiting all types of insurance coverage to requiring the burial of or cremation of fetal tissue. With Amy Coney Barrett at the Supreme Court, we now have a solid 6-3 conservative majority. And anti-choice legislators have publicly said that they are emboldened and they want to reverse Roe v. Wade. We are afraid indeed that if Roe v. Wade were to be weakened or overturned, abortion would be protected in less than half of the states and none of the US territories. We have to make sure, dear Californians, that we protect abortion access in our state. We need to send a clear message to legislators and advocates and the Supreme Court that abortion will be protected in our state. I want to take a moment to discuss the Hyde Amendment. The Hyde Amendment was introduced in 1976 and continues to be renewed by Congress every year. This appropriations bill rider prohibits federal coverage of abortion except in limited cases of rape, incest, or when the pregnancy is life endangering. The Hyde Amendment applies to crucial health coverage like Medicaid and Medicare, as well as individuals who receive health care through the federal government, like federal employees, military personnel, and veterans, as well as Indigenous people receiving health care through the Indian Health Service. However, states can use their own funding to cover abortion. Only 16 states, including California, have opted to do so. Due to the Hyde Amendment, it is estimated that 7.4 million women ages 15 to 49 who are enrolled in Medicaid cannot use their insurance to cover the abortion, except in these very narrow circumstances. Numerous studies demonstrate that the Hyde Amendment falls hardest on women of color, immigrant women, and young women. 31% of Black women of reproductive age and 20% of Latinx women of reproductive age are enrolled in Medicaid, compared to 16% of their white counterparts. Without insurance coverage of abortion, those seeking abortions must pay for it out of pocket. The cost varies on location and type and other factors. But just to paint you a picture, an abortion just at the first trimester costs between $500 to over $1,000. How can people make these payments when most Americans don't even have $400 saved for emergencies? In addition to out-of-pocket costs for the abortion itself, there are costs associated with travel, childcare costs, and income loss because of the time that's taken to leave work. Multiple studies indicate that the inability to afford an abortion places pregnant individuals further into poverty and harms their health, as well as the well-being of their current and future children. Make no mistake, this is a reproductive justice issue. This is an issue that impacts women, their families, and their communities. I want to also talk to you about California. Many patients must travel long distances to obtain abortions here in our states. Even when we have increased insurance coverage here in California, abortion patients have travel burdens associated with abortions because providers are concentrated in certain areas. One study found that 12% of Medi-Cal enrollees have to travel 50 miles or more to get an abortion in California. In addition, women obtaining second trimester or later abortions, as well as rural residents, have to travel 50 miles or more to obtain an abortion. How can that be when folks do not have access to their own transportation? Now, as Tanisha was mentioning, now you have to go in person to get a medication abortion that can be dispensed at home. We are risking the lives of women here in California. But allow me to end on a more positive note. Along with our partners, Black Women for Wellness, Access Reproductive Justice, Planned Parenthood of California, and NARAL of California, we are reintroducing a bill that will remove cost-sharing requirements for abortions in commercial plans in our states. That means that while Californians do have a right to insurance coverage of abortions, they were still subject to pay for cost sharing, like deductibles and copays and coinsurance. We're very excited that if this bill gets enacted, they don't have to worry about that part of their care. In a moment where women are experiencing the most significant job losses, folks cannot pay for food or for rent or other basic necessities, we're proud to do what's right for California. I ask you to support this bill and join us in our broader work to make abortion access a complete reality for all. Thank you again for your time.
Thank you, Fabiola. That was amazing information. One, to understand who is being impacted by abortion across the country, and also where we need to go. And that California, even though we think of it as this, golden state of reproductive opportunities, that there's still work for us to be doing here at home. And so that's always a great reminder about how far we need to go, and that even though you might have good books or good laws on the books, that still doesn't mean that there's still access for people and tangible access. So I'm going to take a moment to ask um, the attendees a question. And so we have a poll question that is going to pop up on your screen. And I believe the question is, self-managed abortion is a great way to expand access to abortion, and everyone should be able to access abortion pills without consulting a clinician. This is a do you believe this or not question. And so I will give a couple of seconds for people to fill that out, and then we will share the answers. And then in the meantime, I'm going to pull up our next presenter bio. Boo, boo, boo. There you go. You have two Michelles. All right. So I think I will, right now our poll is sitting at 71% people believe yes, and 30% or 29% of folks are no on this. And so hopefully we get everybody to the yes side by the end of this call. So in the meantime, I want to introduce our next presenter, Dr. Michelle Bratcher-Goodwin, who is a Chancellor Professor at the University of California, Irvine, and founding director of the Center for Biotechnology and Global Health Policy. She is a recipient of the 2020-2021 Distinguished Senior Faculty Award for Research, the highest honor bestowed by the University of California. She is also the first law professor at the University of California, Irvine to receive this award. She is an elected member of the American Law Institute, as well as an elected fellow of the American Bar Foundation and the Hastings Center. She is also the co-host of On the Issue with Michelle Goodwin at Miss Magazine. Professor Goodwin's scholarship is hailed as exceptional in the New England Journal of Medicine. She has been featured in Politico, Salon, Forbes, The Washington Post, The New York Times, Los Angeles Times, The Boston Globe, Chicago Sun-Times, NPR, anything that y'all have seen on news, Michelle has been there. And so Goodwin, is very accomplished in these ways. Goodwin's publication includes 5 books and over 80 articles, essays, and book chapters, as well as numerous commentaries. She serves on the executive committee and national board of the American Civil Liberties Union, ACLU. She is highly sought after voice on civil liberties, civil rights, reproductive rights, and justice and cultural politics. Prior to teaching law, she was a Gilder Lehrman postdoctorate fellow at Yale University. I am super honored to welcome Dr. Goodwin, who I am always in awe of her intellect and her flyness, because I have never not seen Dr. Goodwin show up and not be just fly as all everything, with the glasses, the earrings, just yes. So thank you for joining us today. I'm super excited to hear what you have to say, and super honored for you to be here. And I'm going to turn the mic over to you.
It's a pleasure and an honor to be with you and to my fellow co-panelists who are already dropping the microphone and just sharing wonderful knowledge, both from the heart and the mind. What a beautiful spirit in thinking about the issues that we're confronting today. So I want to start off with thinking about spacing us in historic terms. I think if any time in our history we understand the urgency and the importance of rooting our conversations in the foundations of this nation, and the fact that this is a nation that, while there were those who wanted a constitution that forged equality and liberty, it was one that abandoned those particular principles for the indigenous people who were already on and part of these lands, the enslaved and kidnapped people who were brought to these lands, and then for the others who migrated to these lands who happened to be not Northern white Europeans. And there's a significant legacy of all of this that's covered in my work, but it's covered in many other people's works too. So I lift up this conversation as one to engage with a direct topic, but also the intersecting aspects of it, which I think are so critically important. And we could tie these threads in so many different ways, but let me start here with talking just a little bit about Sojourner Truth, because I love anniversaries, and here's an anniversary, which is that in 1851, Sojourner Truth made a speech that was profound. Many people associate it with "Ain't I a Woman?" But here's the speech and why the speech is relevant for us today. People frame it as one that was about chivalry. And she did, in fact, mention that, look, nobody really pays attention to Black women. And certainly they don't treat Black women like they treat white women, such as opening up a carriage door and caring about whether she steps in mud or not. But the speech was more profound than that, because in that speech, she said, "And I bore 13 children, and nearly each one snatched from my arms, and nobody heard my cry but God. Ain't I a woman?" And if that isn't reproductive justice, if that isn't thinking about reproductive rights, if that isn't thinking about reproductive health, I don't know what is. And I think it's a perfect way to start our conversation today, or to continue the conversation. As we think about the enterprise of how we manage and care for reproductive health, it's important to understand the legacy that then flowed, the legacy that she was a part of and that happened during that, because nearly 100% of reproductive care around that time was actually being managed by women. These are the nurse midwives. Half of them were Black, they were also indigenous, and they were white. And I wish we had enough time for it. We don't, but I do want to lay this with us, which is the following. Can you imagine what that would have meant if they would have been able to continue the enterprise that they were already involved in post-slavery and into Reconstruction and into the coming century? But their legacies, their work was thwarted through the professionalization of gynecology and obstetrics, through the work of the American Medical Association, through people like Horatio Storer and Joseph B. These were individuals who were hell-bent on forging the fields of gynecology and obstetrics, which would and did leave out women. And they were deeply concerned about the competition that women held. And so they used then means to describe these women as being unhygienic, evil, unsavory. When we think about how abortion became politicized and how it became criminalized, we could talk about it in its modern, but it actually was something that was connected to an economics. It was connected to insecure white men who were beginning obstetrics and gynecology, being concerned that they were being told that they were doing nothing more than what Black women were already doing. They wrote about it in their pamphlets and their brochures. They wrote about these insecurities of being compared to these women, and the fact that there were male surgeons who were saying, "You're doing women's work." Now, if you have to think about it, right, we know millennia ago, there weren't guys going around in lab coats and stethoscopes on the plains in Africa, or through the sand dunes in parts of the world, or what. Those are women who were in the care of other women. And to just think about the kind of political storm that brought together the end of abortion, in the 19th century, it was done by these men who wanted to push these women out, and abortion became the tool to do so. It became the tool because these men had to figure out how to get rid of these women. And they did a number of things. One part of that storm was, was lobbying legislators and saying that these women should be licensed. Another part of it is that women who thought, well, okay, let me invest and then go to medical school, were barred because the American Medical Association didn't want that, and neither did these folks want that at all. And then third was to say that these women were engaged in a really evil practice. And part of that evil practice was the practice of abortion. And so we went from about 100%, nearly 100% of women being involved in reproductive health care as nurse midwives to go to around 1% decades later once we get into the 20th century. But what I want to talk with you is about more than just that, but it's important to understand that legacy. And it's important to understand the political nature of that and the political tools that were done by early obstetricians and gynecologists to get rid of women and to use the practice of gynecology, of abortion, and also contraception, using those as the means of getting women, disassociating women from the practice of healthcare that was related to people who had uteri. But what does that mean once we fast forward into the 20th century, a time that is murky in its own political ways? Murky and awful because we see the nature of the kind of political football that women's reproductive capacities become, because this country has no problem in its leadership with enforcing eugenics, with cultivating eugenics, and its application against the poorest of women in this country. The norm being that this is a country that should try to rid itself of people who are considered socially and morally unfit. Its application only against the poorest of people. The United States Supreme Court takes up a eugenics law in 1927 in a case called Buck v. Bell. And in that case, it addressed a poor white girl who was 16 years old and had been raped by her employer's nephew. She becomes pregnant and she gives birth. And the state of Virginia to assign her to what it called its colony. And at the colony, it was a place in which they sterilized folks, would sterilize people as young as 11 and 12 years old. And they wanted this case to go before the Supreme Court because they wanted to make sure that it was legal, that what they were doing. Now, they thought it was legal, but what they really wanted is to ramp it up. It was a model law. And if this model law could be successful before the US Supreme Court, then it would mean that it's not only legal in Virginia to forcibly sterilize people who are thought of as unfit to reproduce again. And of course, if they to reproduce, then it's the whole part of the country of people that you just can simply get rid of. And so that's case for the United States Supreme Court. And Justice Oliver Wendell Holmes says that 3 generations of ills are enough, because he's saying, well, Carrie's mother wasn't reproducing, Carrie be reproducing, and we want to make sure that future generations will not be able to reproduce from this particular line. Justice Oliver Wendell Holmes says that the authority that a state has to force inoculation, the power that a state has to convey inoculation, right, vaccine, is broad enough to cover snipping the fallopian tubes. That's his language in 1927. And perhaps it will surprise some people on the call, maybe not, but it's exactly this law and it's exactly this case that the Nazis in Germany turned to. It's exactly this law, which then serves as the foundation for what the Nazis picked up and what they started doing in terms of sterilizing individuals. They enact a eugenics law that's based on the Virginia law. Years later, during World War II and after, during the Nuremberg trials, when the Nazi doctors are in their trial and are defending themselves, what they cite is US law. What they say is, we were doing nothing different than what you were doing in the United States. The platform of that is worth thinking about in the wake of very recent cases, including in California in its and carceral system of Black women being forcibly sterilized, coercively sterilized, without even knowing that that was taking place, or the sterilizations taking place in detention centers, also against the will of the individuals who are in those detention centers. And the fact that the people who've had to be robust and courageous and whistleblowers have been women of color who've put their jobs on the line to call attention to this. So as we think about Roe v. Wade and where we are today, and I want to turn quickly to thinking about criminalization, there's so much more to talk about than just abortion, which is critically important. And let me just put a pin in the following, which is that the narrative about abortion rights has been hijacked. Science has been hijacked. Science has been hijacked. A person is 14 times more likely to die by carrying a pregnancy to term in the United States than by having an abortion. Now, if we looked at that data alone, I would think if this were something that involved men, men were 14 times more likely to die if they did X is Y. We would see people in government saying, choose the one where you're least likely to die. Let's help to underwrite the one where you're least likely to die. The choice is yours, but we actually hope that you won't die. And we as a government want to show we care about your life, we care about your personhood. But the importance of understanding history is to understand, especially when we're thinking about women of color and the poor, this is a nation where its government has never articulated a concern about those groups of people. We see that through eugenics. We see that through slavery. We see that during Jim Crow. It's also important to know, historically and rooted in science, is that the World Health Organization has long said that terminating a pregnancy and abortion, contemporary abortion under the medical science that we have today, is as safe as a penicillin shot. But we've been far removed from the science and healthcare of this because the narratives around abortion have been hijacked, and because at the bottom scale of this, the personhood question, we've not been invested in the personhood of the people that we're talking about. And that is a part of the narrative that's really important for us to fill in. So that even after Roe v. Wade, where Roe itself was a liberating decision, the opinion itself is actually quite nuanced. For as much as we could criticize it and critique, indeed, Justice Blackmun did something revolutionary if you were to scale and look at constitutional law cases that involved women, because this was, for the first time, a kind of general recognition of the personhood of women. It's an opinion that's 7-2, with 5 Republican appointed justices in the majority saying we need to decriminalize abortion. And of course, the backdrop of this is that there are back alley abortions that are taking place all across the country. We have the medical wards in New York, in Chicago, and other places. In the maternity wards, over half of the people who are there are people who are dying because they've had a botched abortion. We're in a backdrop where there are people who have died on the dining room tables, bled out in bathtubs, died in motel rooms because they had no other choice to turn to except the people who were really unqualified to help them and assist them in terminating their pregnancies. These were the deaths that were born out of desperation. What Justice Blackmun spoke to in Roe v. Wade was to speak to that, those dangers. One of the first things that he talks about is about how in the United States, abortion had not historically been criminalized. That was the first important piece. But the second was about the dignity of women. He talked about how having an unwanted pregnancy where you're forced to carry it to term interferes with one's life, interferes with education, can interfere with one's career. All of these things, this was revolutionary for a Supreme Court that had previously held in Buck v. Bell, it's fine to terminate, it's fine to make sure that these people never get the chance to reproduce or control their pregnancies at all. But even more, the history of the Supreme Court saying it was completely fine that states deny women the right to vote, that it was completely fine that a state like Illinois, that women can never become attorneys, that it was completely fine, any number of things, fine that women not serve on juries, fine that women not be able to work in certain establishments. This case was an important recognition, but let me close with the following, which was that Roe is only one piece of the pie, because what we've seen is the chipping away of that decision. We saw that in Planned Parenthood v. Casey, which is really the authority that we're living under right now, in the early 1990s. And we saw that even after Roe, in cases like Maher, where the Supreme Court says, well, you know, there's no obligation to provide, to make sure that women who are economically disenfranchised have access to this constitutional right. We'll make sure that they have access if they want to carry a pregnancy to term, but not if they want to terminate a pregnancy. Those distinctions are now baked into Supreme Court jurisprudence. And what we've seen in the wake of all of that, and the attacks on abortion, have also been the attacks on being pregnant, the attacks that include arrests of women for falling down steps during pregnancy, the idea being that this is some sneaky way of trying to terminate a pregnancy. We've seen in the state of Alabama ramping up and the arrest of hundreds of women because their medical professionals have disclosed confidential patient information, and prosecutors have then pursued these women, and in many instances there have been arrests and charges of endangering their fetuses. In the state of California, there's a case that's right now of a person who may be facing, is facing criminal charges because of a stillbirth that she experienced. We've seen in states like North Carolina, South Carolina, Mississippi, and others with individuals charged with manslaughter or charged with depraved heart murder because of having a stillbirth. This era of criminalization is like a cap on the attacks of abortion access and abortion rights. There's much more that could be said about all of this, and there are steps that must be taken by this next administration to right the wrongs that we've seen. And these wrongs that we have seen have been essentially the continued effort to deny the personhood of people who become pregnant, and very specifically along the lines of people who happen to be of color. I want to cede my time now because we have wonderful people who are in the queue to talk with you, but I thank you very much for inviting me to be with you today and to share a few remarks. So thank you, Nafis.
Thank you so much, Dr. Goodwin. Dropped all the mics, and really also in pure reproductive justice fashion, and talking about both the right to have children and the right to not have children, right? Which is a core piece of RJ, and the history, the complicated history that this country has had with this eugenics movement, and how some people have bodily autonomy and some people don't, and the complications around that. And so definitely want to get more into that in our question space. But we do have another panelist that I am absolutely excited to bring on, another friend and person that I've worked with for a long time. Not that long, I'm not that old, but a person who I love dearly in DC, and who I always call in DC to do something. So thank you for always taking my calls. Michelle Batchelor, I'm going to invite to the conversation, and she is the Vice President of Government Affairs for In Our Own Voice, Black Women's Reproductive Justice Agenda, develops and promotes and partners with organizations to advance a strategic policy agenda supporting Black women's access to safe abortions, contraceptives, and comprehensive sex education. Michelle received her master's degree in clinical psychology from Roosevelt University and a bachelor's degree in economics from Spelman. Whoop, whoop. Prior to In Our Own Voice, she oversaw the domestic and global programming at the National Alliance of Alliance of State and Territorial AIDS Director in ASTAD, including Black African American youth and women's HIV portfolios. There, she also developed the Minority Leadership Program. Michelle worked at the Chicago Department of Public Health for 10 years, managing several programs across the STD, HIV, AIDS, substance abuse and mental health division. Ms. Bachelor is a founder and former co-chair for the Illinois Women of African Descent Coalition and Divas Dining, a social networking health promotion initiative. And so I am super proud and honored, and thank you for coming and visiting us today all the way from DC, to talk with us a little bit about um, the Black reproductive justice agenda, and what that's looking like. And so we'll jump right into it. And then after that, I think I have another polling question for folks, but we're going to jump into Michelle first, so we can hear all the good things you got to say.
Hi, Norbese. Always good to see you. And thank you so much for having me. Always wonderful. I could sit and just actually listen to Dr. Goodwin and Fabiola for a good long while. But I appreciate you having me here. As you mentioned, I am with In Our Own Voice, National Black Women's Reproductive Justice Agenda. We are a reproductive justice organization that is focused on lifting up the voices of Black women at the national and regional levels. We're fighting to secure reproductive justice for Black women, femmes, and girls, queer, trans, gender, non-conforming people, and youth. And we do have 9 strategic partners, of which one is Black Women for Wellness. I think, the significant thing is that all of our partners are reproductive justice organizations and leaders that are really focused on lifting up Black communities. And so it's a real honor to work for this organization and with these partners. So I'm just gonna, Dr. Goodwin and Fabiola covered a lot of ground, and particularly Fabiola talked about a lot of the things that are happening, particularly legally, policy, statewide, and nationally. But as we think about this being the 48th anniversary of Roe v. Wade, it was a historic event, and it provided unrestricted rights to reproductive health care in the form of abortion, but it didn't do as much as we had hoped for access. And I think we've talked a little bit about that, but as reproductive justice advocates, we really believe that every person has the right to make fundamental decisions about how and when and if they grow their family, and that they can have whatever mechanism of a family in a safe environment where they are free from violence, they have economic security, they have community security. And so, as has been mentioned, abortion is a safe, legal, it is time sensitive reproductive health option. And, we have to be able to trust Black women, people, to be able to make the personal decision about what is best for themselves as far as creating their families. And I just want to point out a couple things. We've done some polling because, you'll hear a lot that the Black community doesn't support abortion, or, that conservatives don't. But, we asked specifically, when putting aside their personal beliefs, we found that 80% of Black people said that abortion should remain legal and women should be able to get safe abortion. 76%, and this was a poll of just Black people, agreed that health insurance should cover service. And as Fabiola mentioned, Roe v. Wade was made abortion legal in 1973. And then just 3 years later, Congress passed what is called the Hyde Amendment. And the Hyde Amendment is a terrible piece of legislation that bans federal funding for abortion under Medicaid. And I think what probably like gets to me the most is that this is voted in every single year into the budget, into the federal budget. So, you know, we have our legislators that are on our side, but yet they still vote for this every single year to restrict federal funds from being used for this very necessary, safe reproductive health care. And I think, you know, if we think about where to act, that is definitely a place that we want to focus on. And I think, you know, I know, you know, and we are celebrating this historic week. You know, we have a new administration. It's been a tough 4 years, but it's been even longer than that we've had restrictions on abortion. And, you know, I'm going to deviate. I had a whole script, but, you know, I think you all have covered so much, you know, and so while I was sitting here, the White House put out their statement on Roe v. Wade. It is a very nice statement. It includes, you know, they acknowledge that access to reproductive health care is an economic issue. It is a safety issue, and it is a racial justice issue. So very nice statement. I think what has caught me is they never say the word abortion in this statement. And I think, you know, so what that signals to me, and I don't think any of us were ever under the impression that this, you know, we have a new administration, we have a Congress for the first time, that we have a slight majority in the House, and we break even in the Senate. So, you know, we know it's not going to be a cakewalk, but how can you protect something if you can't even say it? And I think that's kind of we have a lot of work to do in the advocacy community, because, you know, I think that's a missed opportunity. We are hearing different things about, you know, what Congress is and isn't going to do. I am going to highlight a couple of the things that we really are advocating for, because we do think we have an opportunity, but we're going to have to really do a lot of heavy lifting and pushing to pass legislation that will improve access. Again, because a right does not guarantee access. And we've seen that whole, you know, through all of since 1973. So I am going to talk a little bit about, Fabiola mentioned the Hyde Amendment. We are really looking to pass what is known as the Each Women's Act, or it's being reintroduced as just the Each Act. We want a clean budget from the administration and from Congress that allows low-income individuals to use healthcare coverage they already have to cover all reproductive health services, including abortion care and contraceptives, because there are also limitations on that as well. So we are pushing hard for that. Another thing is we want to pass the Stop Deceptive Advertising for Women's Healthcare Act. And, you know, we're still a little bit from California, and but this would prohibit unregulated and unlicensed entities or individuals from using coercive or deceptive practices to deceive patients about abortion care, including false advertising, print. And so we're talking specifically about crisis pregnancy centers, as was mentioned previously, that in many states are able and are mandated to give false information to people. A lot of times they're set up literally next door to a legit medical facility. They you know, coerce people that are going for medical services to come to them instead. And then it's very deceptive. It's amazing that our legal environment even supports this, you know, that there are policies that allow this to happen. We're also looking to pass the Abortion is Healthcare Everywhere Act. And this is legislation that would repeal the Helms Amendment, which would remove distinctions between abortion care and other reproductive health care in countries where we provide funds. So this is, and as you mentioned, I had done global work before, and in the midst of it, they passed legislation that basically said that if you had a federal contract to work in any country, or if a country took any US dollars, they could not do any referrals for abortion. They definitely could not perform abortions. And if they did, they could not take advantage of federal US funds. Also looking to pass the Women's Health Protection Act. And this law passed federal laws to preempt states' efforts to functionally limit access to reproductive health care through restrictions, regulations, and requirements. And it's similar to what Fabiola, or addresses what Fabiola mentioned. There are some states that have a trigger laws and things in place, anticipating that, with this new SCOTUS, conservative SCOTUS, that Supreme Court, that they will, do away with Roe v. Wade. And so if that happens, states can immediately, make it illegal in their states as well. So we want the Women's Health Protection Act. And then some other things are that we want to prohibit the use and abuse of religiosity. People have probably heard a lot about what are called reason bans or restrictions that are based on people's conscience clause about their religious beliefs. And so if you're an employer, you could, not include reproductive health coverage. And I think, it relates a lot to what Dr. Goodwin's talking about of, regulating women's bodies. I mean, because these same restrictions aren't included for Viagra or any of the, medical needs that a man would have. And so we really want some legislation that would prohibit that use and abuse of religion. And we want, I could go on. I think, there are a lot of things, and those are the things specifically related to abortion. But, as we've heard, reproductive justice is not just about abortion. It's not just about, whether we have a child or not. It's about all the things that influence how we come to the decisions and honoring those decisions and the bodily autonomy that all of us deserve and as a human right. And so, we definitely are focused on, the policies that improve access to the abortion process. And, but, there's so many other things, and, including economic justice. We need a livable wage. I know that this administration is going to, and already has, put out that $15 minimum wage is going to be the standard, federal standard. That's great, I think, if you live in Wisconsin, maybe. But is that a livable wage in LA? I don't know. I've never lived in LA, but I've been. I can only imagine that is not a livable wage, because I think it comes to, like, I should have looked this up, like $31,000 a year. So is that, a livable wage for an individual? And I think the other thing, economic wise, we know, historically, we have not been able to build wealth. And so that there is no hereditary wealth. So there have to be, and that impacts how and when we're able to have families, how we're able to provide for our families. We need to be able to have protections in housing. We're in the middle of a pandemic. It shouldn't even be an issue. There should be a moratorium on evictions, because that is just a basic human right. We need shelter. We need paid leave. We need workplace protections. We know Black and Brown people are the essential workers during this pandemic that are being most impacted, most harmed by the virus, but don't have a choice but to go to work, can't take a leave of absence to, recover. So we need protections, workplace protections. Another thing that very much so is a reproductive justice issue is that we have access to just to the services. There are not, I think someone mentioned like the distance people have to travel to get to care. Okay, that's great. That doesn't even work if you are in a rural place. We need telehealth to be an option. We need mail service to be an option, particularly in early term abortions, so that people don't have to put themselves at risk during a pandemic. And if they don't have access to public transportation or a car, or they're in a rural setting, that there are options. Nobody should be limited or restricted from being able to make reproductive choices for themselves and their families just because they live in a more remote area or the infrastructure is not built up. We need to build up the infrastructure. And then the other thing I think it's been mentioned is the courts and the judges. So this administration does have the opportunity. The last administration went hard and placed a lot of judges. Obviously, they've stacked the Supreme Court, and they did a really good job of stacking many of the federal courts. But there's still a lot of vacancies. I believe there's close to 200. And we need, those courts are important to us. They're important to us for, abortion rights and access. They're important to us because we know that Black and Brown people end up in court, that the courts have devastated our communities and our families. And so in our advocacy, we need to focus on the courts as well. We need to, and then of course with that, without saying the voting, we've got to vote for the judges. And that's a tough thing. I know when I look at my down ballot and I see 50 million names, and I usually just try to go for the ones that women that sound Black or, of a, maybe of a minority community. And I'm pretty well informed, and I don't even do the research for that, but it does have an impact. And so those are some of the things, and those are our expectations for this administration and for Congress. We need them to rescind all the terrible things. Trump, just before he left, put in place just terrible things like, doing away with and rewriting, whitewashing history with the 1776 project, and doing away with cultural sensitivity training within the federal agencies because that was divisive. I think an insurgency is pretty divisive, but let's not give people real facts, real history, and keep them dumb. So anyway, I hope I covered kind of what you wanted, Norbese, with the policies, and let me know if you want me to go any more into the weeds with them. But I just wanted to give a brief overview of at least what we're doing here in DC, and with our partners, Black Women for Wellness, and our other Black RJ partners are really advocating for the pieces of legislation I discussed, but then also trying to work with other partners from economic justice, from housing justice, from food justice, so that we're really making that connection between reproductive and bodily autonomy and all the other social, psychosocial things that impact people and how we're able to live our lives. I'll stop there.
You, Michelle. No, that was wonderful, and also thank you for sharing the polling information, because I think it's really important when folks start thinking about Black folks and the conversation about the conversation about, you know, do Black people feel, or do they support abortion rights? I remember having a conversation with I won't say what office, but a federal office legislator who was like, well, you know, we care about abortion, but Black folks don't across the country. And actually, that's not true. And I think that's an important point. And also thinking about who are the folks who are feeding that message right out, and who is it serving? So I do think I really appreciate that conversation. And so I do think we have one more poll question that we can send to folks, or maybe we don't. Oh, yeah, we do. Okay, so the second poll question is, in the US, abortion restriction laws have been used to charge women who have suffered pregnancies, loss, such as miscarriages and stillbirth with crimes as a serious matter. So this is a little bit of a test question. So if you were paying attention, you will know the answer listening to folks. But yeah, it's in the US, abortion restriction laws have been used to charge women who have suffered pregnancy loss, such as miscarriages and stillbirth, with crimes as serious as murder. So we're going to give that a couple of more seconds. With that, I also like to invite the full panel back up. I know we only have a couple of minutes, but I know I have a couple of questions for you all. And again, if people have questions, you can throw it in the Q&A. Let me switch this to gallery view. But yes, definitely would like to invite folks back up. And then I'll give the poll a couple of seconds. Actually, I'll just end the poll. And so we have 86% said yes and 14% said no. So I believe the answer was yes. Going to Dr. From what we heard today, that not only is that something that happened in the past, that people are actually still doing this right now in terms of using different pieces of legislation, some pieces of legislation that is actually supposed to protect pregnant folks as a way to charge and go after or be tricky around abortion access. So with that being said, I think my first question that really popped up for me was every one of you all talked about the historicness of what has happened over abortion access, and that we're not really very safe right now. We know that Trump has put over 200 folks in the federal courts. And that doesn't go away with the new president. We know the Supreme Court is, I think, at is it 6-3 or 6-3, right? I want to say right leaning, but it's probably, there's probably stronger words that can be used for that. And so I guess for just regular folks, what are the next steps? What do we do to make sure that not only do we roll back many of the abortion restrictions that we've seen, but actually paint the picture of what rural abortion access looks like? And if you can also share, what does that look like? We've heard a lot about all the things that are wrong with abortion access. So I was also wondering, so it's a two-part question. What does that look like when it's right? Is there other countries that are doing it right? And also, what can regular folks do to move us in that direction? And I'll open it up for whoever wants to start first. If anybody wants to start first.
I mean, I could start. You said what does it look like, and I went into this not fantasy because I don't think it's fantasy, but I was like, I don't know. Someone finds himself, the ideal. Someone finds himself pregnant, and for whatever reason, they have realized that the pregnancy is not what they want right now and want to terminate the pregnancy. And in a perfect world, they can call up their local provider and say, I'd like to make an appointment, and their local provider answers quickly because they're not overwhelmed and they have the money they need, so they're fully staffed. And they get an appointment that day and they go in, and depending on where they are, or take that back, step back, they call depending on where they are in the pregnancy. They say, okay, where's your pharmacy? We'll call in the prescription. But if it's that's not appropriate, they can go in, or if they may prefer to go in and meet with their provider. They have a wonderful conversation about what the procedure entails, what they need, and then they are able to, the provider says, confirms that this is what they want, and they go in and they have the procedure, and then they're sent home and they're able to care for their current children, go back to work, whatever their life situation is, prepare for their exam the next day, whatever it is. So I don't know, my mind went there when you asked that question.
I just say that I concur. I think we want to think about, what does dignity look like? This is sort of basic human dignity look like when you're in medical care. And it certainly doesn't look like having to go through picket lines. It doesn't look like being demoralized by legislators in your state. It doesn't mean like having to feel guilted. It isn't something where the possibility of criminal charges may be hovering around you because you're considering, your right options for you. And yet we've singled out in this particular space, all of those dynamics exist. So attention to wiping that away so that achieving the best medical care looks like achieving the best medical care if you were getting a vasectomy, because nobody getting a vasectomy has to go through any of that. Speaking of over lunchtime and being able to go back to work, if one were to read the narratives of men in vasectomies, that's how easy it is. Was back in the lab, without having any kind of shaming, stigmatization, people in Congress, people in the legislature, making that person feel guilty about having had that procedure. So there are ways of thinking about it, I think, along those particular lines.
I love this question because I love to dream and think, like I'm thinking about like a beautiful day, and you make your decision and you're able to, first of all, there's universal health care, so cost is not a barrier. And if you want to go to the doctor, or a provider, you can. If you want to do it at home, you can do that too. Or if you want to do it in the car before picking up your children, you can certainly do that. But like Dr. Goodwin said, just do it with dignity, under your own terms, in the ways that you want. Um, I think a lot about, as we're thinking about the future, I'm thinking a lot about like what my ancestors did and how the delivery of healthcare took place with a community that supports me, where I'm not stigmatized, where I can do this just like I can do whatever other healthcare intervention under my own terms, in the ways that I want, and I am not stigmatized.
So thank you for those dreams. And I think also one of the things that we talk about at Black Women for Wellness a lot is this idea of what choice looks like, right? And if you are choosing an abortion because of economic issues, is that really a choice? If you would have made a different decision, if you had a living wage, or if you had safe housing, right? And so how all those pieces move together, right, when we're thinking about abortion access and how intersectional it is. With that being said, I love hearing the dreams. I also wanted to kind of go back because I am a bit of a history nerd. And for kind of my last question, because I know we're running short on time, is what does it, when did abortion restrictions start to happen in this country and why? Because it wasn't always the case when we were here. And so I'm curious on this idea of, the country was founded, and then all of a sudden you see some abortion restrictions. And then after you see, then, you know, you saw women dying the way Dr. Goodwin was sharing about folks who don't want to be pregnant, absolutely will do everything that they can not to be pregnant. We get Roe v. Wade. We had some space where abortion access had expanded or only expanded, but it was a little bit more freer. And then it started restrictions. And so I'm curious on like, why did it start in the first place on restrictions? If anybody has any ideas or commentary on that.
Well, I'll start off and then welcome my wonderful co-panelists. You know, anti-abortion legislating began as a means of getting rid of midwives, right? Even with the Catholic Church, abortion was not a problem until quickening, right? This becomes rooted in America's a perfect storm of anti-immigration, racism because of, Civil War coming to an end. If you read what these anti-abortionists wrote, they wrote about needing white women after the Civil War to spread their loins, going south and north and west, right? It was really about, part of it was about white supremacy, right? These folks coming out of slavery, these people will swamp us, too many of them, right? And all of that, of course, is stereotypic. And then now we need white women in service of this country. And the way you're going to be in service of this country, because we don't care about your labor. We've already said we like you being at home. And what we want you to do is to create more babies so that we can maintain white supremacy and white majoritarian control. This is at the same time of anti-immigration movements, right? So we can't talk about this without talking about the Page Act. A lot of people take for granted that if you were Asian, you could not be naturalized in this country until the mid part of the last century. We really take that for granted. Take a step and think about that. No naturalization if you're Asian. The Page Act meant that Asian women were not even supposed to be able to immigrate into this country. All of that is about white supremacy. Abortion becomes a tool. That's all it is. And the tool shifts depending upon which way we want white supremacy to go, which is then why we could be in the 1920s being like, yes, for sterilization. It's a tool, whichever tool is serving the political elites at a particular time. And it is never about protecting the interest of people who can become pregnant. Not at all. And especially not if they happen to be poor and if they happen to be people of color. Anthony Comstock is a part of this too, right? The kind of anti-contraception movement, that's definitely a part of it. But once it becomes instantiated that abortion is evil because it's done by these evil midwives, then that had a lot of power. And it helped that the American Medical Association was a part of that. And let me just say one thing, the AMA has come out to apologize. But its apology has been long, long overdue, because in the wake of all of that, as Black medical schools were coming to rise and Black doctors wanted to be members of the American Medical Association, they specifically said, well, no, you can't be members because you admit women, right? So these histories are entangled and intertwined all together. And so then it's no wonder that there's a National Medical Association, because that's where people of color had to go because they were blocked out of the AMA. And the AMA was a driving force. Get rid of these midwives, get rid of abortion, keep men in control. And that's about money and power. None of it has ever been about healthcare, our health and safety, not at all.
Thank you for that quick word. You dropped a whole bunch.
I'm about to just like throw the mic at Dr.
It's like, oh, in the program because there's nothing else to say. But no, I think we really goes to and how important it is to really see the intersections of that history. And to also, when we have the conversation about abortion, to like base it in what it was really about, right? Because as you see the laws kind of expand and contract, and folks think this is about healthcare, it seems that it very much has some other nefarious reasons, that it's also like really based in white supremacy. And just also knowing that conversation around AMA and docs and midwives, and also why our current system and how we give healthcare, delivery healthcare right now is also the way it is.
If I can just take 30 seconds to just read to you what they wrote, and it puts it all in context. So this comes from Dr. Joseph DeGlee, who is prominent in the AMA. He led this platform, the AMA. Here is what he presented in a 1915 speech, which then was later published. He said, "The midwife is a relic of barbarism. In civilized countries, midwife is wrong, always been wrong. Midwife has been a drag on the progress of science and the art of obstetrics. Her existence stunts the one and degrades the other. For many centuries, she perverted obstetrics from obtaining any standing at all amongst the science of medicine. Even after midwifery was practiced by some of the most brilliant men in the profession, she still stunted obstetrics and gynecology." These are his words. And so do we need to know anything more about the men who are looking to take over?
Right. It also reminds me of a lot of the conversations that we're having right now here in California about providers and scope of practice, which is like the fire issue of all fire issues in the state of being able, who is the folks who are able to provide abortions, provide healthcare, to provide, obstetrics, I can't say that word very well, and gynecology and all those pieces. And so I think that is a really interesting point, and also the juxtaposition on how abortion restrictions for whiteness was going a certain way, but there was still this very eugenics policies that were being practiced on women of color. And particularly also here in California, where we were really good at eugenics, so good that we taught the Nazis how to do it well. And just the history that's particularly here in California, again, another place that we try to act like is the golden state. And I love my state, I do. But I'm also wanting to like look up what's going on. And so with that, I want to thank our esteemed panel for dropping all the mics today, and for bringing and grounding Roe v. Wade and the intersectional space that I believe it deserves, and what that means for women of color, for Black women, about that and the history of it, and also where we need to go. So I am super juiced. I appreciate you all for coming through this morning with us. And we look forward to having more conversations. Black Women for Wellness Action Project is partnering with InHelp, like Fabiola said, to do some abortion access policy. So you should hear about that later today or Monday, as well as we have some exciting things around maternal care coming up and other reproductive. We're looking from the full spectrum. And so we hope and wish that you all will join the organization, sign up to get emails, see you, Dr. Goodwin, because it is past 10:30. So I hope that you jump into those conversations. And then also make sure that you follow us on Facebook, Twitter, and Instagram. There you go. That's social medias now. And, be well. So thank you again for our panel, and thank you all for being here today. And I will bid y'all adieu on this. Hopefully they will get sunny Friday, but right now it's very overcast in Los Angeles. Not Sunday. What's today? Friday. Sorry, y'all, COVID. Friday afternoon. Bye, y'all.
Thank you. Bye.
Thank you. Bye-bye.